Welcome. We are here for our second edition of Small Talk, Big Issues with Marie-Ève Laporte, who is a professor at the Sorbonne Business School, where she is also responsible for the MBA in healthcare management. Marie-Ève specializes in consumer behavior and notably behavior in healthcare. And I'm also very happy to be able to call her my friend and my colleague, since I also teach the Sorbonne Business School. So Marie-Ève, welcome.
Thank you. Hello.
Hello. So Marie-Ève, as you know, we're going to spend 5 or 10 minutes chatting. So I have 3 questions for you, 3 brief questions, and I would like to get started right away. Marie-Ève, you are an expert in patient behavior. And particularly, I know that you are working a lot in profiling and understanding patient behavior with respect to behavioral risks, notably around adherence.
Yes.
So my first question to you is the following. How do you see the future of behavioral diagnostics, if you will, in healthcare?
I think it's absolutely key to understand a patient behavior because we sometimes think that people are just purely rational and that they estimate costs and benefits and then take their decisions. But there are so many other variables and things we don't necessarily are aware of. For example, of course, the social environment, the way we think we are perceived by others, the way we see ourselves, all these things interfere with the way, in fact, we behave. And that's not just a question of attitude, then intent, and then behavior. There are many things which can really intervene in between and make it change. So I think it's absolutely fascinating to work on it. And it's so important because if you consider, for example, something you know very well, observance, if you consider observance, there are many people who don't observe their treatments. When you know that chronic illness, they are responsible for 70% of all diseases worldwide. So that's very important to treat these persons well and that they take that treatment. But in fact, 50% of them don't observe the treatment. And that's not because they don't understand it or they don't just want to bother their doctor. There are many other factors, and that's probably the main thing we could work on to improve people's health in general.
Well, certainly the WHO agrees with you. And interestingly, if we look at the future of it, clearly we need more, right, of these kinds of diagnostic tools. And how do you see them changing as time goes by? Because we've had things like the Mariski questionnaire, the Hill-Bone questionnaire, these kinds of questionnaires that exist. And how do you see these, what do you see the future of these kinds of diagnostics?
I think the future is really in linking qualitative data and quantitative data, and not just figures, but also knowing more about the way people see things, their environment, their psychological traits, and many other things, and not just the fact that they take or they don't take their treatments, all the things around it. And that means a different way to measure it, not just if they intend to take their treatment, but all the other things around. So that's more complete, taking into account other types of variables, like social variables, attitudinal variables, many other things, not just the fact they take it or don't take it.
You know, it's interesting because as you know, the entire idea really about these series of videos is digital patient support, right? And when you start talking about taking into account other measures, then we start moving likewise into the digital realm, right?
Yes.
Which leads to the next question in terms of connected devices.
Right.
How do you see these as fitting into this gathering of the different types of data that you're talking about?
I think they are going to really change the way we can know about patients. We see that already with diabetes, for example, with these new tools which appear, and now we are able to know many things about the patients. the way they took their treatment, but also the way their glycemia evolved, and based on what they ate, and all these things. And so these connected devices are key to better understand behaviors. They are key for the patients because now they can know better how they behave and how their own body reacts to insulin, for example. And it's key also in the exchange of information with their doctor. So I think these devices, they are going to totally change the way we are able to interact with patients and the way patients can themselves be empowered and take ownership of their own treatment.
So that raises the next question, which was my third question for you. How do you fit together the qualitative and the quantitative? So we've talked about connected devices. We can be monitoring people in terms of their glycemia, in terms of their movement, in terms of all kinds of things. But there's also the qualitative element. We've been working together on qualitative questionnaires, for instance, and it seems to me that in many cases they're viewed as not being connected. So how do you tie together the quantitative ongoing stream of data that you get from connected devices or even claims data to the qualitative input that you get through, let's say, sophisticated digital questionnaires?
I think you need first to really get to know the person, not the patient, but the person. And for these things, there are many measures you can get. And so that there would be questionnaires, but which are more open. I think probably you need also to have like an interview with the person to know more about the person, about his or her environment, the way they live, the fears they have, maybe the risks they perceive. And so the kind of persons they are, and not just their behaviors and the measures that you mentioned, which are extremely important, but to be able to connect it with the way also they perceive the world, life, health. Are they health-oriented? Are they prevention-oriented? All these things are very important because they are going to change the way they will react to one and the same thing. If you have same events happening to two different persons, they won't behave the same way. So you need to know the persons. So with the connected device, you have the possibility to get information on the way they behave, but you can also connect it with the information you get from the person. I think that's the key is here, connecting this qualitative data with the quantitative data, which so far we were not able to do properly. But now with the new connected devices, that's something we can really do, and with also good measurement tools, that's key to have these measurement tools. But we have them now.
We do. This raises another question, which wasn't on my list of questions to ask you, but I'm going to allow this. It's a nice thing about running the interview. You can allow whatever you want, right? What do you think is the role of the physician in this, in making a behavioral diagnosis? So let's assume that the physician has access to the kinds of analysis, if not the raw data, that we're talking about. Physicians, let's just focus here in France. Physicians tend not to be trained either in the importance of adherence, the crisis that non-adherence represents, nor in what to do about it with a patient. And do you think that there should be an effort, even in medical schools, for instance, to include education around these topics for future healthcare professionals?
Oh yes, definitely. I think it's key, and sometimes of physicians they do it. Physicians who work as anesthetists, they tend to do it. But if you take surgeons, they don't usually do it, for example. So it depends on the type of physicians you have. But I think it's very important to include it in their studies, but maybe not just the physicians. I think there are other types of persons around the patients who are key in that. For example, nurses. And in hospitals now, you have new types of nurses who are here to help the patient know about the whole journey, the patient journey. And these persons, these nurses, they usually have specific interviews with the patients, and they try to know more about the patient, not just the patient as a patient, but the way he or she lives. For example, if they live in a building, at what store do they live? Are they alone? What kind of life do they have? What kind of threats do they see? All these things, so that they adapt it. And the nurses then they tend to make a report to the anesthetist, for example, to the surgeon, so that they take it into account in the patient journey and how long the patient will stay in the hospital, for example. So, and this information would be very important also to have on a numeric platform so that you can connect it.
I agree entirely. Now, I lied when I said I only had 3 questions. My next question is I'm asking to everybody, which is why? I mean, is there some kind of epiphany that led you to want to work in healthcare? I mean, originally neither of us used to work in healthcare a long time ago, right? So, what do you find particularly interesting, and particularly around this question of patient behavior? Is there something that really springs out for you and that led you to this?
I find it absolutely fascinating. Among all the different subjects I've had the opportunity to work on, I think that's the most fascinating one. And I had a personal epiphany, as you say, as I myself was a patient. I had breast cancer, and then that means from one day to the next, my whole life changed totally. And I was not perceived as the same person. I was not a human being anymore. I was a patient with cancer. And then I really thought, but did I change in the meantime? And in fact, no. So that was the first step, to better understanding patient behavior, interactions with physicians, nurses, all people in the healthcare ecosystem, and also trying to understand how it can help in the disease and in the treatments and all these things. So that was my first stage, then to change in life and becoming an academic, and then specializing in patient behavior, obviously because of this epiphany, as you say.
That's a real epiphany. It's true. And perhaps effectively, there should be more and more people working around this domain who come from an experience of being a patient, as opposed to purely being an experience of a healthcare professional, right?
Definitely. I had very nice discussions with the physicians who took care of me, and they said they learned a lot from understanding how myself I lived these things. And then it helped us to work as a team against cancer, and not just them curing me and me being a patient, but being active in it within a team. And I really think it changes the way you live this kind of illness. And that's one of the things which was very important to me. And then I think the other thing is I realized it helped in the way I get out of it. Yeah. And I think it helped also the physicians to talk with their own patients. So for these 2 things, I think it's very important, and I think it should be part of their studies. But there are many things to know. I know it. My own daughter now is in this process, in this type of study. So I know they have so many things to study. But I think it's very important. And now the research I do in hospitals, for example, that's very important questions also for physicians. But sometimes they are themselves afraid of that because they kind of put a barrier and not to get hurt themselves. But I think it should be part of the process. And what they told me is they can't do it with any patients. Some patients don't want to be empowered. I think we should respect it. It depends on their own life and what they got before that, and the way they perceive life and death. That's ontologic questions, in fact. But when there is this success, I think that it really helps the whole process, and it makes life easier for everybody. Some of the physicians I saw, they told me that when the patient comes in, the way the patient behaves and talks, they can tell whether it will be fine or not for the patient.
Oh.
I was quite surprised to hear that, but I can believe it. Yes, I see what they mean. And among the different physicians I interviewed also for my research after that, in fact, I could see a very big difference between the physicians who had themselves been patients or who had people very close to them who had been patients. They didn't work the same way. And I think they were much better, in fact.
That's really interesting. So having been on both sides, effectively, they can undoubtedly empathize.
Yes.
And you raise an interesting point, because when you say some patients don't want to be empowered, again, we come back to the importance of understanding a behavioral profile. You know, there are some people who really want to feel like they're taken in hand, and they'll just get on with their life where somebody else thinks about their treatment, and others for whom that would be highly, highly disturbing. You know, so again, we come back to this question of profiling.
Exactly, and I think we should be very open-minded to that, not judge people. They do what they can with what they have, but I think it's very important to get where they are to see how to address these things with them.
Well, Marie-Eve, thank you very much. This has been really, really, really interesting, very illuminating. And I'm the lucky one here because I get to see you pretty soon, I think, whereas
Yes.
our viewers, unfortunately, are going to have to wait for your next YouTube appearance or public speaking engagement. So thank you very, very much, and I'll see you very soon.
Thank you. Goodbye. Thank you very much, Kevin.